This eMultiple Sclerosis review program is presented by DKB Med Radio.
Even more concerning is the fact that this medication can sometimes cause side effects that might make the patient feel worse. And that's the reason we don't recommend them as the first-line options. Instead, we want to focus on a treatment that have been shown to be safer and perhaps more effective.
Clinical approaches to MS fatigue. Welcome to eMultiple Sclerosis Review. Fatigue. It's one of the most common complaints providers hear from their patients with MS. MS fatigue can interfere with work life, home life, and play life. Compared to non-MS fatigue, it occurs more often, episodes last longer, and recovery requires more time. How connected is MS fatigue to a patient's depression or degree of physical impairment? What can clinicians do to better identify MS fatigue? And most importantly, what do they need to know to provide management effectively tailored to each patient? To discuss these issues, we're joined today by Dr. Bardia Nourbakhsh, an MS specialist and associate professor of neurology at the Johns Hopkins University School of Medicine. For our guest disclosures and additional CME information, please go to our website, emsreview.org, and select the Volume 6, Issue 4 link. I'm Bob Busker, executive producer of DKB Med's e-literature review video programs. Dr. Nourbakhsh, thank you for joining us today.
I'm glad to be here.
Our overall learning objective for today's program is to assess the safety and efficacy of treatments used to manage fatigue in people with MS. And our first focus under that learning objective is to describe why medications should not be the first option for managing patients with MS who present with fatigue. So that being said, if you would please, Dr. Nourbakhsh, take us to the clinic and start us out with a patient scenario.
Sure. I'm going to tell you a story about a 52-year-old man who has primary progressive MS, and he's coming to your clinic for his annual routine neurological visit. He has been treated with ocrelizumab for his PPMS. Today, his neurological examination and his MRIs have remained completely stable compared to his prior visit last year. However, he tells us that he lacks energy, and this lack of energy and fatigue has negatively affected his work and social activities. The fatigue is worse during the summer month and also during the later hours of the day compared to early morning. He tells us that his sleep is really good. He sleeps around 7 or 8 hours a day. And his only physical activity is walking his dog 3 or 4 blocks every day. His primary care doctor has recently completed some labs, including a complete blood count, a metabolic panel, and a thyroid test, and all of them were completely normal. He tells us that he's heard from his MS support group that a couple of medications, including modafinil and amantadine, are quite effective treatments for MS fatigue, and asks us to prescribe one of these medications for him.
Modafinil and amantadine. I know you've authored some important research in this area, Doctor, particularly in comparing the safety and efficacy of these wakefulness medications. Can you give us a brief summary of your research?
Absolutely. So we completed a large randomized controlled trial of 3 medications specifically, modafinil, amantadine, and methylphenidate. And we compared them to placebo, assessing their efficacy in improving MS fatigue. We showed that the benefit of all these 3 medications is as high or as good as a placebo for improving fatigue. In other words, placebo was effective in reducing MS fatigue, and all these 3 medications were only as effective as a placebo in reducing MS fatigue.
Thank you, Doctor. So, bottom line now, how would you address this patient's request for one of these drugs?
So, very simple. I'm going to tell him that no medication has been found to be conclusively more effective than a placebo for MS fatigue. And these medications can cause side effects or adverse effects. So considering these two important facts, we do not recommend medications as the first line of treatment for people who complain from MS fatigue.
In your experience, doctor, do your patients readily accept that kind of response?
Great question. As you explained, that might not be always the case. So in those cases, I would explain that I understand how exhausting and frustrating it can be to deal with fatigue, and the fact that it is completely natural to want a solution that can help the patient feel better. However, research has shown that the medications that we currently have and we currently use and prescribe for MS fatigue do not work better than the placebo, meaning that they don't provide a real lasting improvement in fatigue for most people with MS fatigue. Even more concerning is the fact that this medication can sometimes cause side effects that might make the patient feel worse. And that's the reason we don't recommend them as the first line options. Instead, we want to focus on a treatment that have been shown to be safer and perhaps more effective. Eventually, we have to show that we are here to support the patient in finding the best approach in managing their fatigue, and we can work together to explore the options that will help them feel better and feel in control and improve their quality of life at the end.
So, to better manage this patient's fatigue, what would you recommend?
Thank you for asking that. So there are two options that I would think are first line for addressing MS fatigue. Either starting a new exercise program, which I prefer to be under the supervision of physical therapists, for example, or referring the patient for cognitive behavioral therapy for fatigue.
Well, let's focus on that first suggestion. What if this patient agrees to begin an exercise program with a physical therapist? Okay, and now it's 3 months later, and he comes back to you and reports that despite starting a balanced exercise program, his fatigue remains considerable and he often feels even worse than when he started the program. What would be your next step in managing his fatigue?
Sure. So for this patient or for patients who do not respond to exercise, I think that trying cognitive behavioral therapy for fatigue would be a good next step in the management.
Well, talk to us, please, about the evidence supporting cognitive behavioral therapy, or CBT, for alleviating MS fatigue.
Absolutely. Several randomized clinical trials and meta-analysis have supported using cognitive behavioral therapy as an effective form of treatment for MS fatigue. In fact, a relatively recent meta-analysis from the UK reported that balance and combined exercise and cognitive behavioral therapy are all effective modalities for improving MS fatigue. However, the certainty of evidence for CBT was higher than the balance and combined exercise.
One more what if type of question, doctor. What if this patient had been prescribed modafinil by another clinician and reported an improvement in his fatigue? Based on what we've been discussing about modafinil's efficacy and safety, would you recommend stopping that medication?
That is a great question. Although it's possible that the improvement being reported by the patient is related to the placebo effect of modafinil. However, it's quite possible that the patient belonged to a subgroup of patients who have a better response to modafinil as compared to a placebo. So if the patient reports an improvement of the fatigue and there is no clear adverse event, such as insomnia or worsening of anxiety, I would not recommend discontinuing the medication at this point.
Thank you, Dr. Nourbakhsh. Let's return now to the key learning focus for this part of our conversation. to describe why medication should not be the first options for managing patients with MS who present with fatigue. What are the most important things you'd want our learners to take back to their practices?
So I think that there is no medication that has been found conclusively being more effective than a placebo for MS fatigue at this point. And the medications that we are currently using for MS fatigue cause adverse events such as insomnia and anxiety. Overall, medications should not be the first line of treatment for most patients who complain from MS fatigue. And instead, non-pharmacological interventions such as exercise and particularly cognitive behavioral therapy should be prioritized and should be considered first-line treatments for fatigue in the majority of patients with MS and fatigue.
Nice summation, Doctor. And we'll return with Dr. Bardia Nourbakhsh from Johns Hopkins in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eMultipleSclerosis review program, focused on assessing the safety and efficacy of treatments used to manage fatigue in people with MS. We've been speaking with Dr. Bardia Nourbakhsh, an MS specialist from the Department of Neurology at the Johns Hopkins University School of Medicine, about why medication should not be the first option for managing patients with MS who complain of fatigue. Let's turn now to our second key learning focus. Explain why assessing a patient's sleep through history or paraclinical means is an important part of the evaluation of a patient with MS fatigue. So if you would please, Dr. Nourbakhsh, take us back to the clinic with another patient scenario.
Absolutely. So this time, a 59-year-old woman with a history of relapsing remitting MS comes to our clinic for her annual visit. Around 2 years ago, she stopped her disease-modifying therapy, which was glatiramer acetate, after 15 years of being clinically and radiologically stable. Today, she says that she has had no energy in the past 6 months. She has gained about 35 pounds, and working has become very difficult more recently. Upon further questioning, she reports she's been easy to fall asleep at work and at home while she's watching TV or reading a book.
No energy, excessive weight gain, and inappropriate somnolence. How likely is it that stopping her glatiramer 2 years ago is the underlying reason for her current symptoms?
I would say it is very unlikely. However, just to make sure that her MS is not reactivated after stopping her disease-modifying therapy, I would obtain a new set of MRIs. MS disease activity or reactivation of MS can be a cause of worsening fatigue. But in this setting, in a patient at this age of around 60 years old, and after being stable clinically and radiologically for many years, MS disease reactivation is very unlikely.
Very unlikely, but you want to positively rule out disease reactivation. So what if you get that new set of MRIs and they show no significant change compared to last year's MRIs? What would be your next step in your management?
Sure. At this point, I think that doing a clinical screening for depression and also some routine labs, including checking her hemoglobin levels and thyroid function test, would be the next step. The reason is comorbidities such as depression, anemia, and hypothyroidism are common secondary causes of fatigue, even in patients with MS.
Okay. Again, I want to ask you a what-if question. What if her labs come back normal and her screening for depression is negative? What do you do next?
I thought that there were some clues in her history. She reported some recent considerable weight gain and also excessive daytime sleepiness. So, considering these two issues, I would become concerned that obstructive sleep apnea might be underlying cause of her worsening fatigue, and I would refer her for polysomnography.
And the sleep study results?
She was found to have moderate to severe obstructive sleep apnea, and the sleep doctor started her on CPAP.
Obstructive sleep apnea, or OSA, can be a primary cause of interrupted sleep and concomitant fatigue. Did using her CPAP resolve the mystery of her symptoms? What happened at her next visit?
Sure. She comes in during her next visit and reports that although she has been compliant with using the CPAP, her daytime sleepiness and fatigue are still quite bothersome.
That's disappointing. What would you recommend the treating clinician do at this point?
At this point, I would consult one of my sleep medicine colleagues to make sure that the treatment of her obstructive sleep apnea is optimized. If that is the case, I would think that using a weight-promoting agent such as modafinil can probably be helpful at this point.
Well, talk to us, if you would, please, doctor, about the trials of modafinil for fatigue and daytime sleepiness in patients with MS. What were the findings?
Sure. So modafinil or other weight-promoting agents have not been specifically tested in a population of patients with MS with concomitant fatigue and excessive daytime sleepiness. However, in the post-hoc analysis of two relatively large clinical trials, one of them was cited by me before, subgroups of patients with concomitant fatigue and daytime sleepiness experience more or better fatigue relief in response to modafinil as compared to the placebo. Generally, I would prefer to see these results being replicated in a separate study, but I think it is reasonable to make clinical decisions based on the post-hoc analysis of two relatively large clinical trials.
An interesting case. Thank you for bringing it to us, doctor. Our learning focus for this part of our discussion is to explain why assessing a patient's sleep through history and paraclinical means is an important part of the evaluation of a patient with MS fatigue. For our learners managing these patients, what are the key things they need to be aware of?
Sure. So I think that assessing patients with MS fatigue for secondary causes of fatigue, such as depression, anemia, or thyroid dysfunction, is important. Also, screening patients for common sleep disorders, such as sleep apnea, and even further testing and evaluation with sleep studies may reveal the underlying cause as an important contributor to fatigue. Also, weight-promoting agents such as modafinil may have a role in the treatment of patients with ongoing MS fatigue and concomitant excessive daytime sleepiness.
From the Johns Hopkins University School of Medicine, Dr. Bardia Nourbakhsh, thank you for sharing your knowledge and expertise in today's eMultiple Sclerosis Review program.
It's been my pleasure. Thank you.
For eMultiple Sclerosis Review, I'm Bob Busker.